The broadcast is now starting. All attendees are in listen-only mode.
Hello, folks. My name is Charlie Grantham with MTM Services, and happy to speak with you all today. As part of our continuing office hours series we're calling Follow the Leaders, today we're going to have an exciting excursion into operationalizing data in the short and long term. I do have some prepared remarks to talk through here. We will have some time for some question and answer period, hopefully, during this. And as always, please feel free to send any questions that you might have into the chat, and we'll try to get those going as well. So thank you, everyone, for joining. I know we probably still have some folks coming in, but with that said, we'll just jump right on into the content. Just a little bit about we at MTM, as many of you may know, and hopefully I got to see some of you in Los Angeles a couple of weeks ago. We're a comprehensive consultation firm that works with folks all over the country. As you can see here, our map is getting pretty full. If there's anybody on the phone from South Dakota, please let me know. I'd love to do some consultation with you and fill in our last little blank there so we can say we're working in all 50 states. But we at MTM work across the country with teams that deal with these challenges every day, and that's what we hope to bring to the conversation today. Again, we have a full suite of folks with everybody's kind of got their own little specialties. We have folks that work in sort of the technology side, myself and Megan, and we've got folks that you know that have been working with same day and just in time, like David and Scott and David Swan and Michael Flora and Joy Fruth for years and years. So feel free to jump in on any of our other webinars that we're going to be delivering here over the next few weeks. And you can listen to some of these folks and the things that they see out there every day. So getting on to a subject matter at hand, let's talk a little bit about data. You know, the truth is we feel like there's all this data out there anyway, right? And we're almost drowning in that much data. So today we're going to talk about some techniques to maybe wrangle that a little bit so that maybe we can be masters of our data and not maybe slaves to it. You know, it's going to take a little bit of time, but hopefully we can get there. But the truth is, nobody likes keying in data. So why do we need it anyway, right? You know, we've got these comprehensive systems that we call electronic health records that we utilize in our practices to, collect all this information. But what are we going to do with it? Well, the truth is we need to use that information that we're gathering. And we need to be able to use it to help us to, run a successful practice. That means be viable, whether that means be viable with, financially or, all the other ways that we need to be viable in our practice, because that means we've also got to use that data to manage our staff. To be effective managers, we have to understand what our staff members are doing every day, how we're delivering services, because ultimately this is all about the reason for the season, so to speak, is to help our clients. We've got to make our systems so that they work and so that we can use them to help us help the folks that need the help. Truth is, we got a lot of data requirements out there, and many of them are right at home in our sort of, what we need at our local level. I sort of break these up into three different groups, both administrative, clinical, and technical. Clinical sort of covering both the clinical and the prescriber side. But, here's some examples. On the administrative side, maybe we need to see the no-show rates. Maybe that's also a little clinical. We need the claims to process. I hear all the time about complex billing situations that systems have a heck of a time with. And I wish it could get better, and hopefully we'll try to make that happen. But maybe you just need to summarize data for reports for your board as an administrator. There's need for all sorts of different types of data. On the clinical side, maybe it's about productivity or the practice. How many of X codes are we doing every day? You know, what sort of breakup of individual therapy to group therapy are our clinicians doing so that we can understand what their practice looks like. And then on the technical side, you know, it's about access to the data. Certainly, we've got to be able to get our hands on it so that we can work on it and use it. But then more to our point today is about how do we operationalize it? How do we use it? How do we take the data and sort of use different, I like to call resolutions in order to look at the data? And we'll talk a little more about that as we go. Truth is, though, there's a lot of other requirements that we have when it comes to data and data systems. You know, we've got all these, and I put in quotes there, the set parameters in data, but then notice the asterisks there. They are subject to change. One thing I know about data requirements and regulations is that they can change with the wind sometimes. And so that means that we must be nimble about our data and understand where things are coming from, how they're utilized, and that sort of thing. Again, regulatory bodies, accreditation folks, our payers, our funders, and others. You know, it seems like there's always another parameter or something that we should be tracking or being able to report on. So what makes good data or bad data? Well, a lot of times it's about, you know, how do we collect it? How are we using our system to have effective data capture? Do we have our workflows generated or our scripts so that our folks are having to jump all around our EHRs to try to fill in all the blanks that we need to fill in? We always have to think about that human element. You know, it is people entering in data, and how can we sort of help them along to make sure that we have the quality in the data that we need in order to use it? We're going to talk about some of those techniques as we go through this morning. And then, of course, we've got to have the ability to retrieve it. So that means the end of all the narrative boxes as much as we can and as much as we love them and cherish the ability for free text. It doesn't help us a lot sort of on the data side. It's always about sort of having a balance. We'll talk about breaking down some of those silos here in a minute. But, you know, there's always that technical requirement where we need to be able to report off some of this stuff. And to be honest, free text blanks are great, but, you know, if you spell as bad as I do, then they're no good in reporting. So, and the truth is, we all make mistakes. You know, it takes a team effort to ensure data quality throughout the data's really life cycle. I call it, there's a lot of chefs in the kitchen, I guess. We've all are entering data from the front desk through clinicians to folks that are in your billing areas and that sort of stuff at the end of the life cycle. But there's a lot of sort of hands in the pot when it comes to this data. So it can be important to have strategies around, monitoring that data and understanding sort of where it fits and how it's working, and are you collecting it correctly? So let's just take a look here at a day in the life of data and just talk about how, as we collect information from a new client coming in the door in my example here, but how does it hit some of those areas that we talked about a little bit earlier? So, for example, we have a new client that comes in and interacts with our frontline staff. Now, as you know, our frontline staff can often be, where a lot of this information is collected. Let's take a look at that. So, I mean, you figure we got some demographics. That's going to be needed by both your local, your regulatory, and your payers. We're going to have employment status or housing status. Maybe that's a CCBHC requirement, or maybe it's a state requirement for some of your funders. You know, we're going to get that payer, that financial information. We've got to assign them to a payer source. So with that information, you know, that's going to have to pass its way on through. Maybe it means we have to get eligibility check or perhaps an authorization, again, to make sure that we satisfy those payer requirements. And then there's the ROIs and the consents and all the paperwork and all the fun that comes in with a new client packet. So there's a substantial amount of information that we're collecting at that front door in that first piece that is crucial throughout our data's sort of lifetime. And it doesn't stop there. Let's say that you're doing same-day access. This client, we've been able to get this frontline information. We schedule them right into an intake with some clinical staff. So now we've got at least a second person, that may be a third person, depending on if they had to go to a financial specialist to get some of their financial information. But so now we've got a clinician that's, performing a service on them. So we're having to record that service, the information about that service, so that we can ultimately send it out to our payers. Maybe it's a diagnosis, getting a treatment plan, and then setting up the follow-up appointments and closing out your note and signing it all off and getting it ready for billing. So just in those 2 episodes where we took somebody in through the front door and then we got them into an intake, maybe that's one thing that we did. We got them into services. But there was a lot of information that was collected and a lot of chances for things to get sort of mussed up a little bit. So the important thing is that we develop our workflow so that we make it easy for our clinicians and our frontline staff to collect this information, but then we have to take it to the next step. And before we get to the next step, let's talk about how do we make it easy for our clients and staff. Well, I suggest that you use the system to your capabilities or whatever. You try to get the most out of the capabilities of your system. And a lot of times that means things like hard and soft stops. Some systems allow it pretty much everywhere, others maybe not so much, and that can be a problem. But with that said, when you can do it, utilize stops. Like, for example, let's say we're trying to calculate BMI for some youth for some CCPHC requirements coming up. So if we have a blank where we're required to put in height and weight, and I know this is very oversimplified, but hopefully this gets my point across here. We put in a height, we don't put in a weight, and it prompts us. And it says, wait a minute, a weight value is required and not entered. How would you like to proceed? Would you like to back up, or do you have an exception? This is a good example here. Let's just say that the client refused, didn't want to be weighed. So we can account for that. Now, why is that important? Well, because when it comes to reporting these things, we can, in our denominators or numerators, we can count this episode in our numerator, and then I'm going to get those mixed up. But we can count this as a proper episode, but then we can also say that this is an exception. And this is the reason that it was exception was because the client refused it. So we can build that sort of functionality that our final reporting to the government or SAMHSA or whoever it is might be, build those pieces into your initial data collection so that it carries through and is able to be reported on. Hopefully that makes a little sense. The other thing is that we've got to trust but verify. And what I mean by that is that we need to create multiple layers of data quality checks until processes are hardwired. Now, what I mean by processes being hardwired is that they happen without people thinking about it. And often what I see is that people concentrate a lot on, we've got some problems, we need to work on that, and people get really fatigued about that. So one of the things that I suggest with teams is that you work on that hardwiring a little along. And what I mean is we try to hardwire one piece this quarter or this month, and then we move on to another subject matter the following quarter or month. The reason for that is hopefully people have made some changes and we have seen some progress. If we've seen enough progress, don't try to get to 100%, move on to the next thing. That way you keep things moving and people don't get stagnated. So how can we do that? How can we keep things from getting stagnated? How can we get data in front of people? Well, certainly dashboards are a way that many folks do that. These would be easy views that people might see first thing as a splash on their EHR. Perhaps it's a daily dashboard view for a manager that might aggregate a lot of different data to bring it in front of somebody. An example here that I've got on the screen is sort of a checkpoint list, sort of a checklist. Did they do everything that they were supposed to? Here, this was an example for a CCBHC where they were, performing services. They had a CCBHC client. They were expected to do certain tests or certain requirements to be completed. Of course, we'd want to see yeses across the board here. And if we do, then we've got some, green charts. It's all about having that sort of visibility into what you're looking at the time, and then being able to make decisions. Here maybe we're looking and saying, all right, what's going on with these two red charts? Who is this provider? Why are they not getting the things done that they need to? Who is it that's getting their stuff done? Who maybe it's not? Or maybe we need to look ahead a little bit in the short term. This next screen here is an example of future appointments, looking in 2 weeks ahead. Who's got space? Who can we try to get folks into? Having that sort of short-term look. Or maybe it's a short-term look both forward and back. This is 14 days on either side of today, this report showing our previous 14-day activities. And you can see the weeks as the Monday, Tuesday, Wednesdays, and Monday through Friday goes through. We have a little bit of activity in this particular example on the weekends. But then we can also see, for example, the show rates for each day down here at the bottom. So we can track and trend that stuff in the short term to see, are we having a problem in a particular place around a particular service? This particular graph here shows activity scheduled for the next 14 days for this particular group. Now, one thing that I'll say about this, unfortunately, in my demo data here is, it looks like nobody likes to have an appointment on Friday. So as you can see, our Monday, Tuesdays are a big day, Wednesday, Thursday, okay, Friday's about half as much or so. Unfortunately, it looks that way out in the wild too, sometimes, folks, I will say. Now, I know what also you're saying is that, wait a minute, there's way too much data for us to try to go through and to run these reports and to try to figure out what's going on. Well, let me make another suggestion, is that you need to create some exception type reports. Maybe there's some places where we need to know where those exceptions are happening. And that can be about setting up some thresholds, some guardrails, and really trying to make sure that your folks are doing things correctly. In our SBQM program product that we have at MTM, one of the charts that I use all the time is called this Outlier Finder 3000. I used to call it the Error Finder, but I got in a lot of trouble for that. So I've moved on to the Outlier Finder now. And what it allows me to do is to look through a whole lot of data really quick. I start on the left-hand side here with my different services, and I've got the maximum amount of time in the last month, let's say, that was recorded for that service, and the minimum amount of time that was recorded for that service. So looking here at my first one here, I've got residential. We've got a minimum of 16 hours, almost 17, and a maximum of about 24 hours. Well, that's about what I would expect for residential. So no harm, no foul. As we go down here, though, what you might notice is the targeted case management goes from 0.13 of an hour to 12 hours and some change. So as we look at the detail and I click on that, I can see that this staff member here on this date, which is blanked out, and this case number had a 12-hour session that started at 1:23 a.m. Anybody ever seen an AM PM error? Well, there's one right there. So there's a billable service that, perhaps has got a wrong time on it. It gets out through the billables, and now we've got a problem with a denial or a payback. But what this can tell us is that on average, cases for targeted case management can last up to about 2.5 or maybe 3 hours. So what I would suggest is that, if you don't have a way to visualize your data like this, perhaps you make an exception report that says, if there's a targeted case management that's over 3 hours, I want to know about it. And you can build those same sorts of guardrails and reporting around all of your services, whether it's a time that's too long or perhaps a time that's too short. Maybe your state has a requirement for, a medical service, a 99213 or 99214, that it has to last a certain amount of time. I think now they're at systems that they manage, but you get the idea. You might want to check on that to see about your timing. There also needs to be a feedback loop. And what I mean by that is that quality is everyone's job, and that we've got to hold staff accountable. There needs to be that feedback loop to try to fix the errors at the point of entry, I guess you might say, or where they happen. A lot of times with billing, what we see is that there's, some issues that need to maybe go back to the clinician. If it just goes back to the clinician's supervisor and it's expected for them to make sure that it gets fixed, maybe there's not a good pathway there. But what we want to do is to make sure that the clinicians know that they're making the mistakes or what mistakes they're making, and so that they can get the proper training. Using your data like this can also highlight those people, and we can decide whether, maybe we just need to go to Charlie's desk and talk to him about some mistakes that he's been making lately. Maybe it's a problem in all of outpatient, and we need to have a lunch and learn and go over the proper steps to document something or to capture some data so that everybody's doing it in the same way. Or maybe we've been to Charlie's desk a few times already, and it's time to head on down to HR. So to that end, when it comes to staff-related quality measures, a lot of times we need to take a step back. I call that a little bit more medium scale, perhaps. Looking at months at the time. What are the trends over time and that sort of thing. So here, for example, we're looking at some doctors. We got Dr. Hook, Dr. Oz, Dr. Who, a couple of other names here. But we're looking at percentages of billable time by CPT code. So, for example, we've got some folks doing 99213s, 99214s, some intakes here, some 90792s. And, a few things jump out on me on this chart. So, for example, here we see that Dr. Zhivago has got 31% that are not reported. They don't have a CPT on them. So they either are non-billable services or something else is going on there. Or we might be looking over here at Dr. Who, who's doing a significant number of 99215s compared to everybody else. So it's those sorts of more medium-term looks to validate service patterns. Well, we can also look at things sort of through different lenses. So this is looking at some front desk staff data capture. How many new clients did we have, and then how many had employee status entered in, and then who did it. So as you can see here, we've got our 5 staff members across the bottom. We're looking at how they entered in employment status, because that's an important metric that we need to have. And as you can see here, Angelo and Martha are at 26 and 41% at not collected, so they're not asking. So that would be a way that we could immediately go to them and say, hey, don't forget, we need to be calculating, we need to be capturing this particular item. Sometimes things jump out at you. So this is start time. Anybody see anything crazy here? Well, oops. Well, we don't deliver services in the middle of the night, so we've got a bunch of AM, PM stuff going on. So that's why it can be important to sort of toss this stuff out and look at it through different lenses. Maybe we looked at it through the service and it looked fine because it had an appropriate amount of time on there. We didn't notice the start time. But now that we're looking at it, versus start time, it tells us a different tale. Now, if you also notice, we've got quite a few services here that start at 0 o'clock, I guess. But generally, those are the daily services that would drop for residential, let's say. That might be expected. So then let's talk a little bit about some longer term looks. So for longer term, it can be tracking, again, you picked your metric. My example here is we were trying to make some adjustments on our intake time. We had lobbied our state and gotten them to reduce some of the requirements for what our intake took. We've redone our intake whole process. We did this in May and June, and we're trying to see if we had any traction with the changes that we've made. So as you can see here, we're tracking for 3 different employees of how long it takes for their session to do a 90791. And as it started out, before we went through this particular exercise, that we were up around 80 or 100 minutes, around 90 minutes or so for our intake sessions. But through work with our documentation and using the data to track our progress, we've been able to see that we've gotten those times down to 45 to 60. So taking data, stringing it out across a long period of time can be used to effectively monitor and validate that changes that you're making are having the desired effect. I would say you can also look at yearly trends. Here's some demo data with the different colors being different years, where you can look at and approximate maybe what your summer slump is. Many facilities that we work with do see that sort of thing. Or maybe you've added a bunch of staff, and we would expect to see our populations go up as the number of people that we can serve increases. So we can also use data for a few other things. And often I work with teams around KPIs, those continuous process improvement markers that we can try to use to keep our staff engaged and to increase our quality across the board in our facilities. So here's an example of tracking some of those tick marks, I guess, that we looked at a little earlier in one of the dashboards. So how many times are people not, that's a deviation here, are they not doing the alcohol use screening and cessation portion of the assessment? So for CCBHC, this is one of the required elements. And as you can see, like for example, Santos here, he was making a lot of mistakes. 10 the first month, 7, 6, 8, and he sort of drops off and disappears. So maybe we can make an assumption of what maybe happened to him. Other folks, we've got Catherine here that's in the red, very little mistakes. Now, Dale started in May. I think it's Dale. No, Brian. I'm Brianna. I can't even read my names here. Brianna in black here started in May, had some issues, got some training, and as you can see, is tracking now well with 0 mistakes. So what that allows us to do is to be able to take that same metric and measure, and then create some KPIs around that. So, for example, a data entry KPI around alcohol use, maybe your stretch goal would be 0 mistakes. That would be a pretty good goal. Exceeding expectation, maybe 1 to 10 mistakes in the course of your year. And then you can see, what some other ones may be. And of course, you'd have to figure out what these values and things would be, but you can see that you can use these and track them across time to be able to understand how your staff are doing. This is, a tangible, quantitative measure that we can use for our quality metrics. Now, I will say this, that there will be the inevitable staff pushback. Now, what do I mean by that? Well, you got to have trust in your data, because the minute you start using your data to manage staff, they're going to try to blow holes in it. So with that said, it's important to take the data that you have and that you collect and to vet it and to make sure that it's good, and to use these quality assurance sort of methodologies that we talked a little about today to verify, validate that data, understand what's going in, where it's captured, so that when these questions do arise, you'll not only be ready for them, but you'll have the right answers to give them. Because here's an example of billable client time by staff over the course of 3 months. Can you imagine what would happen if you showed this to folks that are doing the exact same work for the exact same pay? And you've got some people that are, up around 100 hours a month, and you've got some folks that are doing less than half that. So it can be very brutal sometimes when you look at this data. But what this also tells me is, what do we need to do for Isaac and Philip to try to get them busy? What has broken down in our system so that they're not getting the appointments that Vincent and Tommy are? So there's a lot of pieces and parts to the data and what it can tell us, but making sure that we're looking at it and have confidence in it is certainly a huge part of that. Because the truth is, we've all got different data needs. It looks like we've got about 60 folks on the phone here watching this today. I'm sure many of you have differing needs from data. Maybe HIM or health information is your ball of wax, and it's all about being able to look at those charts and do those investigations or audits. Or maybe you're a clinical director, and for you, it's all about outcomes. What does my population look like? Are we seeing improvement across the board? Maybe you're just a simple provider. And what I mean by that is, you've got your own caseload and you want to know what your clients are doing. Maybe it's financial is your sort of bailiwick. And in that case, it's all about the numbers. How many CPTs are we doing? What does our revenue look like? What's our PPS rate going to be? Or maybe you're just a geek like me and you want to make sure that we're able to get the reports out to the folks and get our state reporting out so that everybody up in the C-suite is happy. So just know that there's a lot of different data needs out there. There's a lot of different ways to attack the data, but the important thing is that you do. Another thing I'd like to sort of bring out here toward the end of my prepared remarks is that it can be very important to create alignment between the expectations of your staff and the capabilities of your staff. Now, not to suggest that many of you are down here with this guy beating on the rocks as far as systems and capabilities go, but maybe some. But what I do know is that staff expectation is often very lofty. Whether it's we want the note to appear on the screen just by thinking about it, or we want to be able to access everything from our phone, our tablet, from home, from wherever, all that universal access. Well, sometimes it's just not there. And unfortunately, that gap between the capability and the expectation is often filled with angst. What I mean is, folks want systems to do things that they can't do. They don't have any understanding about that, and often they get a little upset when it comes to those sorts of things. So for me, one of the important pieces is trying to bring those capabilities and the expectations closer together so that we can remove some of that angst out of the picture. Because the truth is, we've got no shortage of data needs. We've got everybody needs either empirical data or outcomes data, or some payer needs some sort of information here or there. So there's no lack of want for information. And some of the things that you can do to sort of bridge those gaps is remember that this data is an elephant, and we need to sort of take it one bite at a time. And by that, often it may mean additional training for your technical or clinical staff. being able to take this data, operationalize it, utilize it, and bring it out of one system, combine it with information from another, takes some technical skill. We can also help you with that. Remember to collaborate across teams for efficiencies. I often tell the teams that I work with, as an IT guy, it's important to walk a mile in a clinician's shoes so that you can understand what they go through every day to try to make your work as efficient as you can for them. You know, if I was developing an EHR for me, it would be way different than a clinician would tell me to do it. And I would be totally wrong because I don't know how to do that. You do as clinical folks. So it's up to us to use your expertise as a way to implement the systems that are sometimes a little more logical in the way they work. That translation is part of the fun. Remember that there's no workflow too small or too large that can't be improved, whether that means you dissect something down to its finest elements, or we just look overall at how can we streamline a process. We need buy-in from administration when it comes to technology. Know that technology is often not the fix for everything. It takes people doing things with technology to come up with many solutions. And finally, I would just say, don't get discouraged, as data quality efforts can be especially hard at first. It's a big elephant. Take some bites, see what happens. All right, at this time, I'd like to open it up for any questions or discussion that we might have. And also remind you that we've got this webinar series. If you haven't signed up for some of the other sessions, feel free to take out your phone and snap a picture of the barcode there. It'll take you right to where you can do that. Now, the question is going to be, can I figure out how to unmute everybody? Or if you need to unmute. Any questions? Or please feel free to put some in the chat. I think I just made it where you could unmute. Maybe not. Do you see a question? Will we be receiving a copy of this presentation material? I will say that yes, I'm going to, there'll be a PDF version. It'll be on the website where you registered. It'll be right next to that. What data visualization software was I using for my examples? A combination. Some of them came from sample data in our SPQM system. Others were created from Microsoft BI. I think I may have even had a couple that I did in Excel. But the truth is that it's really not about the visualization tool that you use. It's about getting in there and digging into your data some. What services does MTM offer to help upgrade a data analyst skill set? We do have some products around and some work around reporting, looking at the reporting that you're doing now. What are some things that we suggest that you look at? We can help you identify what those data elements are, how to build them. We offer services around looking at your data in total. And seeing how much fluff we've got out there in our sort of assessments and EHRs. Often we see that by using a data mapping situation, that's what we call it, data mapping, where we go in and line out each item that you collect. And then we determine, do you need to? Or was that something that we needed to collect 10 years ago that maybe we don't need to collect anymore? Often we see that, you know, it's easy to add stuff to your assessments and your data collection. It's very infrequent when we remove things. Any other questions? Do I have a cheat sheet of common visualizations you know, I wish I could say I did, Ryan. You know, I often get asked, what's the one report that everybody wants to see? And I would say, I don't know, it depends on what you do, or what you're trying to look at. There are so many ways to pull a report and to visualize it. I often tell teams, you know, that it's even with like a product like Microsoft BI or any of the other ones that are out there, and I just drawing a blank all of a sudden. But anyway, you can take the same data and present it 10 different ways, whether it is in a tabular form or a bar chart or a line chart, or it's set up this way or that. You know, it's sort of like going to Baskin Robbins and you've got all these choices, and then you get the sprinkles and the jimmies and all the other stuff that you get to put on there too. Sorry, I know that's not much of an answer, but follow up with me on email and I'll see what I can do about trying to answer you better there, Brian. Any other questions or comments? All right. Well, folks, I certainly appreciate your time today. It's been a pleasure to talk with you about this exciting subject. But certainly appreciate it. Wait a minute. Let's see if we've got no hands raised, no nothing. So I appreciate it, folks. Thank you very much for coming.